So the next panel, we're going to discuss neuropsychiatric, psychiatric applications of virtual reality. You've heard from all three of our speakers already, so this is a great opportunity to get into a little bit more depth of all the different topics that these guys covered and sort of blew our mind this morning. We did receive some questions earlier, but please, you can continue to submit questions in real time, and the moderator here, Dr. Ishak, will be receiving those if you have your phone. If not, then you won't, but then So Wagi is our vice chair of research and education in our Department of Psychiatry here at Cedars-Sinai, and he has decades of experience as a clinical psychiatrist and as a researcher with a real focus on outcomes research in particular. And he's been working with our group along with Itai Danovich, who you guys met yesterday, exploring how we can interface these technologies in psychiatry. So I'm going to allow Dr. Ishak to sort of kick us off, and you've got some questions, I think, and we'll take it from there. Okay? Thanks.
Thank you so much, Brandon. Thank you all so much for being here today. So just to give you a little bit of a sense of what we've been doing on the psychiatry end, and I think we've got like an amazing panel here to answer more of the questions. But the first overview on the psychiatric side is, I think one important application has been in the education area, and you've heard from great speakers all along about how to do that. Kim and I earlier were talking about applications in psychotherapy training, where you would have, instead of trainees having to struggle with how to start psychotherapy and how to kind of work with patients in psychotherapy, there's a lot of opportunities through new inventions that have not been all applied, because we've actually did one-way mirror supervision. We did even live supervision with earpieces, where basically you're supervising a resident doing psychotherapy live with a supervisor who's not physically in the room. And there's a lot of room to actually apply and create in that area. The other piece, obviously, and has been talked about a lot, is the applications in anxiety disorders. There's still a lot of space in depression that still needs to be explored in virtual reality. A lot of it is about mood elevating, especially with experiences that the group here had done with Brennan, with actually asking patients at the bedside, kind of what's your kind of favorite experience that you do. And the team goes, let's say a patient said, I love going to this park. And they go with a virtual reality camera, and actually they film the park and bring it to the bedside. Here's a patient who's stuck in a hospital bed for days or weeks. And all of a sudden they have their favorite park being brought to them live and re-experience that. Some of these experiences, I think, are pretty unique. So let me get a little bit more into asking each one to introduce yourself and say a little bit about your work. I know that the audience already have seen you, but just to kind of give a little bit more of an overview.
Okay. Hi. My name is Skip Rizzo, and my role is as a director of medical virtual reality at the Institute for Creative Technologies. Basically I got into the area and in a way that I think is probably similar to a lot of folks in this room, where I had a general dissatisfaction with the tools that we had available for the work I was doing, brain injury rehabilitation, working as a clinician, just really primitive paper and pencil stuff. Maybe this is in the early 90s, late 80s, Apple IIe memory builder programs, which were, paper and pencil activities put onto a computer. And then that's what really drove me into wanting to study the application of game technology and VR as a way to specifically address those challenges, to be able to put people in systematic drill and practice training activities, but in the context of a functionally relevant environment, with maybe a little bit of game element into it to keep people engaged and motivated. So that, that's what brought me into the field in the first place. And I'm sure, most of the folks here, your attraction to VR in some part is due to maybe some of the dissatisfaction that you have with the current status quo. That's how I think about this and what I do.
So I'm Kim Bullock, and what's my role? I guess it's whatever I make it up to be, right? But I am a academic psychiatrist, and I'm a clinical educator at Stanford, and I've been given this new role of directing a virtual reality and immersive technology program. But really my role most of the day is seeing patients and being a psychotherapist. And I think what I'm seeing really for myself, my role is to kind of take this technology and disperse it within the tribe that I work with, the network, and harness it for good and transformation and all types of things, and for patient care, for education, for research. So I think I have a lot of, seeing myself as having a lot of roles.
Hi, I'm Jeffrey Gold, and I'm a pediatric psychologist, and I've been at Children's Hospital Los Angeles for about 16 years now, and professor at USC. I direct our pediatric pain management clinic, and so, as I mentioned earlier in my talk, we see kids with a variety of chronic illnesses, chronic pain, but then also I think what was unique for me was that a lot of kids experience something called medical PTSD. And I was trained at the National Center for PTSD in Boston. And so medical PTSD is something that's very relevant to me in the treatment of the kids that we see. Kids come in often with pre-existing trauma in their lives as a function of all types of abuse or victimization, bullying, or community violence, et cetera. And then they get medically traumatized as a function of needle sticks and lumbar punctures and exams and surgeries and et cetera. So in my space, the low-hanging fruit was phlebotomy and IV placements and medical procedures that would collectively add up to medical trauma. And so that was the space that I found myself in, collaborating with Skip Rizzo from USC and one of his graduate students, as I mentioned earlier, Greg Rieger, and our first study was in that space because, hey, if kids can come skipping to phlebotomy, that's a win, right? Because nobody does, nobody wants to. So that's where I got into the VR space, was in that direction. Again, accumulating my interest with what was relevant and needed at the hospital with emerging technologies.
Fantastic, thank you. So we have a first question for Dr. Rizzo. What type of virtual patient experiences are available for the education of medical students?
Well, we have what's called the Standardized Patient Toolkit, and it's an online resource that allows you to build training cases. So you can go on there and author dialogue. There's existing patients, and we're trying to build like an ecosystem of people that have an interest in creating their best training cases, and then keep them as as part of the whole package for the community. So that project's been going for a couple of years now. The prime mover in that project is a fellow by the name of Dr. Brett Talbot, and a former Army doc that now works with us. And he's really driven the application, beyond what we were originally doing. It provides feedback after a clinical encounter. There's different levels. You can do the voice recognition, practice interaction, or there's a thing called Select a Chat, which is a quick and dirty, click on choice options to go through a case relatively quickly. And so, if anybody has an interest in being a part of it, there's no cost. It's a matter of just wanting to participate in the development and create, some of these cases. Just if you get in touch with me, and I can introduce you to Brett Talbot, and we can get you set up, and you can be involved. It's not like rocket science. It's online, So.
Fantastic. Anything to add on the opportunities to teach medical students?
Well, I think it's an area. I mean, if you think about it, standardized actor patients have only been around since 1963. I'm blanking on the guy's name, but he was a USC guy. Barrows, I think, was the last name. And, you know, so and that, when I heard that, I was actually kind of surprised. Like, you know, before 1963, you never had, you know, actual role play training actors, and it's such an important area, but, you know, it's a different philosophy back then. You know, I think that this is necessarily the way of the future. Aside from the medical training, I mean, medical training, you know, whether it's building rapport with a client, making them feel comfortable or attended to, at the same time, you're doing a job where you have to collect information and sometimes you have to give bad news. That is not something that people are born with, and it's not something you get out of a book. And we usually get it by, you know, see one, do one, teach one kind of philosophy. So I think, you know, significant potential for improving, you know, doctor skills in this area. In psychology, which is now where we really want to start pushing a little further, American Psychological Association a few years back put out a manifesto criticizing the fact that in clinical psychology, there really isn't a lot of certification, if you will, in graduate school that people are actually competent therapists. And this cries out for this kind of an application. In fact, one of my vision I have on this in clinical psych is that when you go and get your PhD in clinical psych, the first year you don't see patients. You're usually, you know, doing research or whatever. You know, you read a few books on therapy, you take a couple classes, you know, maybe you role play once or twice with a grad student. But I think what you should have is in that first year, you should carry a caseload of 3 or 4 clients over the course of the year online, but virtual clients, and have these things scripted out where, you know, you check in each week, you sit there for an hour online, you interact with the character, you know, you spend the first month coming up with the diagnosis, and then you find out 2 weeks later that your diagnosis is completely wrong because new information comes out because the patient is feeling more comfortable with you. And to learn all the ebbs and flows of doing good therapy, that can be documented, and you follow the rigors of, you know, taking notes at the end of the session, monthly summaries, quarterly reports, all that stuff in the simulation.
Great, thank you.
Yeah, I would just like to add to that, because at Children's Hospital LA, we have a VR simulation, and I think it is all about cases. You know, you're going in for a surgery, you want to know how many cases your surgeon's done, exactly like the one you're about to go through. And that's only based on experience and years of clinical training. And psychology is the same way, I think what Skip's talking about. But you also see it just doing CPR, you know. If you're rusty and you haven't done it for a long time, you need to be practicing routinely, and I think the VR space is perfect for that. You can get all types of case work that's been programmed sort of behind the curtain for the new clinician who needs to build their case examples and their case experiences, where you can bait and switch and have crossroads and really create more complex cases than one might ever gain as a function. And this is residents, fellows, postdocs, and even faculty. If you're really doing something rare, if you're doing a rare intervention surgically or whatever, it'd be great to have routine practice in doing that.
Absolutely.
Yeah, and I was just thinking, yeah, there's the simulation, but then there's just enhancing the regular curriculum by using VR to teach, you know, neuroanatomy, you know, having flipped classrooms where you could learn some of the material before you come in an engaging way and activate some dopamine so it's not so boring. And then I think the other thing is just also letting people be aware of the evidence base for VR. That's kind of I see as a gap. We're not putting all the evidence about VR out there into the curriculum. So.
Great, thank you. There's another question. Can you speak more about the studies or interventions that leverage the present self versus the future self, especially when considering chronic diseases and the obvious need to relay immediacy of present choices on the future self? And how can the artificial experience be leveraged to bypass the present focus bias and kind of looking into more long-term health? So current self versus future self.
Okay, why is everybody looking at me right now? You want me to go first? This would be fun. This is a great question. I think the embodiment work is part of that, and I think I haven't been a huge online player, but I think that there's this idea of having like a second life or whatever, where you're living this other life and this fantasy life, and that you become that avatar and you play those games and etc. I think that future self and actual self can be played out in those roles. But clearly, when we think about mindfulness and we think about meditation and we think about imagery and we're thinking about our healthy self and we're practicing that in our own mind, I think by living that out in a virtual environment or a mixed environment, like with AR now and whatever else is coming on the horizon, which will be something like AR on steroids, we'll be able to live out that idealized life in that fantasy world or in that altered mixed media world that will be separate from our actual life. But I do think there will be carryover from that into our current health. And I think that's really where you see mindfulness and meditation and guided imagery that drives our body's health and increases our immune system and does that type of work by imagining something else. So there's what you actually do, right? And then what you think you would like to do, or what is your idealized self. So that's just a part of it, but I think it's a great question. And I think there's a lot of tentacles that will run from idealized self to real self.
One of the significant studies that were done was an economic study to compare the present self versus the future self, and I think it's fascinating to see when you create that through virtual reality that actually led people to make more decisions about saving. So they kind of like envision the future self in retirement and the present self now. And I think that's probably the same model that could be taken into like how to take better care of yourself if you have chronic
I think
health
we make cognitive errors in behaviors and assessing harm and risk. And so it would be a great mechanism for correcting those kinds of things. And I also saw that some cultures with language that doesn't have a lot of future tense, I think, actually don't have these biases. So you could like make up for your culture and your language and change those implicit biases that we have culturally and linguistically. I think there's so much potential.
That's awesome. There's another question here is, as we move forward with VR, one, the tolerance level that you would see with drugs and alcohol, whereas you take them slowly, increase the dose to experience the same effects, apply to VR, meaning that you would have tolerance to the effects of VR and now you need more, a higher dose, if you will. Realistically, how frequently will new experiences will need to be developed for patients and how we manage that need?
I mean, that's like saying if you read your first book, and that means, you got to have another book right away, and you got to read more. And I mean, with any media, there's novelty. There's various stages that people go through in their consumption of media, and novelty, understanding what your tastes are after repeated exposure and pursuing those tastes, going to certain movies, reading certain books, liking certain, sci-fi television, and in VR, it's another form of media consumption, and I'm sure, people get accustomed to certain things, but, there's certain TV shows you like to watch and you like to watch them again. How many times have people watched the full series of The Wire or The Sopranos? I mean, you want to revisit some of these things that you're, comfortable with. So, I mean, number one, I don't think we're going to run out of ideas and ways that we create experiences. I mean, look at movies. Probably somebody said in 1930 that, well, there's only, 3 different storylines, that you can do in a movie. Eventually, people are going to get tired of them. Well, you change up the characters, you change up the setting, add different conflict in there. I think it's going to be the same thing in VR. I think there's no shortage of imagination and no shortage of what's things that people are going to be developing. So I don't think people are going to get bored with it.
My clinical experience, I'd be interested in yours, Skip, is that people, especially for anxiety, don't get bored, or even for like mindfulness exercises. I think if you're using it for novelty, the mechanism of novelty, and maybe that's why it doesn't work as well for depression when you're needing to behaviorally activate and you might want more novelty. But people with that are doing mindfulness, I'm really struck this year with most of my patients, they want to do the same ones over and over, and I'm surprised often I don't have a lot of content at this point. But the other thing is, I think, too, you want to think of it as like boosters. How are we using it? They're out like allergy shots. Well, great. If they get bored of it, then they've desensitized. But yeah, they might get resensitized again, and they need to come in and have another dose of the same thing. So I don't think we need as much novelty. Maybe in the beginning when we don't have access to so much novelty. I'm not finding it a problem clinically, but
I just want to add one thing. I think I'm going to take the opposite approach. I actually think that if you're thinking about it as a dose effect, from a consumerism, consumptive point of view, yeah, we're all going to do a lot more. We're going to keep watching and we're going to engage and try out new environments. From a clinical standpoint, I actually think that we'll actually need to do it less, actually, if we're doing a clinical intervention, just like, again, like mindfulness, relaxation. Hypnosis is a perfect example. Maybe it took you 15 minutes to self-hypnotize. Now you can do it in literally less than 10 seconds. And so I think that in the clinical applications of VR, we won't have to use as much of a dose as we did in the beginning. So that's kind of flipping it on its other side.
Great. All right, there's another question. As the technology improves and the distinction between virtual and real worlds blur, would this create a confusion for people and they become unable to distinguish between kind of real world situations? You think, is that a risk?
You know, this is a good question, like the last one was as well. I didn't mean to be disparaging in my comments about it, but, you know, humans have a great capacity to suspend disbelief. You know, going back to the movie metaphor again, we feel when we watch a movie. It's an emotionally evocative experience. But when we leave the theater, the movie's over and you have a reverie of it and everything, you know the difference between what's in your everyday life and that experience you went through. As VR gets better and better and becomes more real, I don't think that's going to change. You know, in the 90s, somebody wrote an article, you know, saying that we have to be real careful with VR, not to use it with people with poor reality testing, like say schizophrenia and so forth. But there's been, you know, probably 10, 15 studies with schizophrenic populations, a lot of it doing cognitive work, you know, that shows that, you know, these were well-picked, you know, people in this category, you know, so, and there wasn't this kind of a thing where they misperceived what was real and what was virtual. Maybe because VR wasn't that good. Maybe as it gets better. But, you know, I don't know. You know, we have to be thoughtful about this. You know, we like to say this is an emotionally evocative technology, it has a lot of power, we can use it for good and make a difference. But, you know, if you're going to say that, you have to say, well, you know, if it's going to have that much impact on people in a positive direction, you got to anticipate that there may be some folks that have you know, problems with it in terms of perhaps, you know, well, on the positive side, you have Jeremy Bailenson work with the, what does he call it, the Omega Proteus effect, where you get to be a superhero in a VR environment, and then after you have that experience, and you're leaving the lab, they have a Confederate out there that walks by and drops a bunch of books, and they find that after you've had that superhero experience, that user is more likely to stop and help the person that dropped the books. You know, you also see in Brad Bushman's work with violent video games, you see the short-lived effect of when kids playing a violent video game as opposed to a different type of game, and then the lab person says, okay, just wait here, the experiment's over, I'll be back, I'm gonna get your parents. And meanwhile, they play an audio recording from in the hall, and it sounds like two people having a fight. And one guy gets beat up, and he's on the, you hear it in the background, you know, and it's like, oh, you broke my ankle, you know, and the other guy goes, that's what you get for going out with my girlfriend, and the door slams, like the person, you know, the perpetrator of the injury left. At that moment, they click a stopwatch, and you hear the guy moaning in the you know, out in the hall. and they time how long does it take for that kid to get up after they played a violent video game versus a non-violent video game to pro-socially help the person out there. And I think it was something like after a non-violent video game, it was 16 seconds. Violent video game, it was 56 seconds. So, you know, here you've got the impact of media on helping someone or not helping someone. And I think these are short-lived effects. I don't think there's been a real solid study, or if you could even do it, looking at violent video games, controlling for all other factors and relating it to criminal behavior other than correlational stuff. So, it's up to, we have to pay attention to this stuff, and there is these short-lived effects we've documented. Is this, part of the carryover delusion of being in a virtual environment or playing a violent video game? Or, I don't know.
Yeah.
I'm rambling, sorry.
Well, I just read the book, The New Dawn of Everything by Jaron Lanier. And so in the short run, no, I don't. I think the change between reality and this new virtual reality, there's not a lot of risk. But I think we're undergoing a human evolution in experience, and I don't know where it's going. I am frankly a little concerned, but I think we're evolving into something different, and we're going to be experiencing life in a very different way.
All right. This question is actually for Kim. The person who asked the question said, I loved what you said about mirror visual feedback and how perceptual illusion can change your brain permanently. Can you comment on how or if this is using virtual reality could be applied to people with chronic diseases, especially in chronic conditions such as diabetes or hypertension, where there is a temporal disconnect between the present self and the future self when considering daily health choices?
Well, yeah, I think this probably applies to implicit bias, and we know, and stereotyping that we know from Jeremy Bailenson lab and the Proteus effect, that you can change those things. I don't know how permanently you might need to keep doing it once in a while to keep that effect, but there is plasticity in our belief systems that translate to behaviors that have impact. I think the motor sensory cortex as well, there's plasticity there. How long lasting it is, I don't know. Even I've talked to Ramachandran about the phantom limb pain. Often those patients have permanent effects. The phantom is just gone for good. Other people, have a hand just hanging there or need to get it, get boosters done. So I think the jury's out about how long that plasticity and how much of a dose you need and how permanent it is. But I definitely think for implicit bias, it'll have health behavioral effects that probably will affect all sorts, because I think lifestyle actually accounts for about 70 to 80% of most diseases and can be reversed with lifestyle interventions.
Another question is, what VR solutions are available right now for patients who want to use VR at home to help manage chronic pain? So actually one application we've used, maybe Brandon, maybe you can speak to that, that would be the best expert on that.
Chronic pain? Yeah. Well, there we go, look at that. Wow, how about that? Applied VR has I think it's called Ease VR, which is a multi-day protocol for chronic pain. Harmon, I don't know if one of our patients here has used it. A couple of them have. So let's hear how that goes from a patient perspective shortly. Maybe we'll wait until. You want to do it right now? You guys want?
Cliffhanger.
Yeah, well, we wait until. But we'll hear about that. That's okay. Yeah.
We hear about it later.
And I think we're almost flashing here too.
Oh, okay.
Yeah, we have a panel coming up.
Yeah,
great.
To be continued.
Yes. So the next one, it's what existing networks, national or otherwise, are available for medical professionals, higher education professionals, and entrepreneurs to connect with a view to sharing experience, knowledge, good practice in the research or application of VR?
Well, the Stanford Consortium, Psychiatry Consortium, so we've got about 200 people, but I think I put out the Twitter and if you just email me, we have a web-based meetings once a month, so it's a kind of a grassroots.
Okay, one more. Is there potential to overuse VR with home use? Is there an addiction potential? So let me take this quick, because I know, Skip, you've already mentioned, that the risk of any intervention is there. There's been a lot that it talked about video game addiction, and also there was even TV addiction, there was certain shows. I think this issue is, at least it's a little understudied, but I'm very curious on what you've seen so far in patients.
I asked this question about 15 years ago to this guy, Myron Kruger. Some of you may recognize that name, one of the early godfathers of VR. Are people going to get addicted to? And he goes, it's not good enough to be addicted to, and it's getting better now. And so, whenever you think about addiction, you got to think about, well, what behavior is it replacing? Is somebody that's spending 5 or 6 hours, if it's possible, in a VR headset, what were they doing with that 5 or 6 hours before? Were they practicing the violin? Were they taking cooking classes? Or were they sitting on their can watching TV or playing video games? I think this is something I think we need to pay attention to and study, particularly as this stuff gets better and more compelling. But, even with video game addiction, people actually go to video game Olympics and compete. And it's like, well, what value judgment do we make on how somebody spends their activity? You don't think twice when you see an Olympic gymnast that's 14 years old that spends 8 hours a day training for this moment because, it's a great accomplishment. But is there an impact that that child has had in that training that's removed them from other activities of growing up as a child? But we don't seem to have a criticism about that, or practicing the violin or guitar. We don't think anything of that. Do we have to look at consumption of digital media in the same light?
Right. I guess interference with functioning would be something that we'll be looking at. So we'll bring this panel to wrap it up. Sorry for going a little bit over time, but thank you so much for your active listening.